Ocular Pathology Review, Part 5, The Eyelids and Orbit.
From the Department of Pathology at the Wills Eye Hospital and the Sidney Kimmel Medical College at Thomas Jefferson University. The eyelids are flaps of skin that protect the eye and provide a moist chamber necessary for corneal transparency. The upper eyelid is larger. It is roughly rectangular in configuration. It has a longer tarsal plate and more meibomian glands. In contrast, the lower lid has a shorter tarsal plate, it's smaller, and it has a roughly triangular configuration. Histopathologically, the anterior surface of the eyelid is lined by a delicate skin. The tarsal conjunctiva is, the tarsal plate is lined by tarsal conjunctiva. There's a mucocutaneous junction near the lid margin. We have bundles of orbicularis muscle in the middle of the lid and cut in cross-section anterior to the tarsal plate, and modified hairs, the lashes at the lid margin. The eyelid skin is very delicate and generally lacks reedy ridges. We have an epidermis and a dermis, a basal cell layer, a squamous cell layer, also called a prickle cell layer, stratum spinosum or Malpighian layer, a granular cell layer, and a delicate horny layer, stratum corneum of keratin. Here are some of the terms that are applied by dermatopathologists to skin lesions. Acanthosis refers to thickening of the prickle cell layer or stratum spinosum. Hyperkeratosis is thickening of the keratin layer. In hyperkeratosis, the granular cell layer is present. In parakeratosis, the nuclei tend to be retained within the surface layer of keratin, and there is no granular cell layer. Parakeratosis tends to occur when there's more rapid cellular proliferation. A classic example of parakeratosis occurs on the surface of actinic keratoses, one of the precursor lesions for squamous cell carcinoma. We also see partial replacement of the epidermis by atypical squamous cells, and we can see they are in contrast to the normal epidermis at the left, and then there's actinic elastosis in the underlying dermis. Acantholysis refers to spaces that develop between adjacent squamous cells. Acantholysis and the presence of focal squamous differentiation, called squamous eddies, occurs in a form of irritated seborrheic keratosis called IFK, or inverted follicular keratosis. Dyskeratosis refers to the keratinization of single squamous cells within the epithelium. We see a fair number of benign eyelid lesions. We have our inflammatory lesions. Hordeolums or styes really don't make it to the pathology laboratory, but we do see a significant number of chalazions. We have several types of cysts, epidermal inclusion cysts, and more commonly the cysts that are derived from sweat glands, ecrine and apocrine hydrocystomas, papillomas, skin tags, which are also called acrocordons, lots of SEB-Ks, seborrheic keratoses, and occasionally tissue from xanthelasmas. I don't really have a good clinical photograph of a hordeolum or stye. This is actually a lid abscess. Styes are acute, generally staphylococcal infections involving either lash follicles, which are external hordeolums, or meibomian glands, which are internal hordeolums. This is a example of a external hordeolum in the photomicrograph. Chalazions are chronic lipogranulomas. You can sort of think of them as a foreign body reaction to lipid material that gets out of its normal compartment into the tissues, where it tends to be quite irritating. Histopathologically, a characteristic feature of the presence of empty lipid vacuoles. They're empty in the sections. They contain lipid in the patient, which was dissolved out by tissue processing. The empty lipid vacuoles are surrounded by epithelioid histiocytes, and there's frequently non-granulomatoous inflammation with lymphocytes and plasma cells as well. So, chalazions, chronic lipogranuloma. A good reason to examine them histopathologically is that occasionally malignant tumors like sebaceous gland carcinoma can mimic chalazions clinically. This is a hair follicle that has multiple organisms. These are Demodex mites, Demodex follicularum, very, very common, more common in patients who have so-called seborrheic blepharitis. These are 100, 200 microns in length. They have 8 legs. Here's a short movie from Dr. Henry Perry showing the Demodex wiggling around in a preparation. Probably everybody has some degree of Demodex. They also occur in the ears. I think they were actually first found in earwax. Another critter that can occur in the lashes are pubic lice, crab lice. These are the nits. There's a few lice seen here. I guess this is somewhat of an STD. Here's a scanning micrograph showing the big claws of the lice that sort of look like lobsters or crabs. Here's another one on a lash with a nit or egg case at the bottom. Eyelid cysts. Eyelid cysts include epidermal inclusion cysts, the things that are called sebaceous cysts but aren't sebaceous at all. We have our 2 types of sweat ductal cysts, or hydrocystomas, eccrine cysts deriving from eccrine sweat glands, and apocrine cysts arising from the apocrine glands of Moll. Then we'll talk about cystic dermoids in one of the subsequent lectures. Epidermal inclusion cysts result from the blockage of a single epidermal appendage, a hair follicle. They tend to be round or oval. They're unilocular, and they're filled with keratin debris. They are lined by keratinized stratified squamous epithelium that does not have epidermal appendages. Again, the whole cyst is derived from a single epidermal appendage. Eccrine hydrocystomas have a propensity for the canthi. They tend to be sort of translucent. They're filled with watery fluid. They may be multilocular, and they're lined by a dual layer of sweat ductal epithelium, and typically have this eosinophilic serous fluid. Now, the Moll gland cysts, the apocrine hydrocystomas, are interesting. They may appear blue or very dark clinically and can be confused with melanocytic lesions. They appear dark because they're filled with brown fluid, as we see in the gross section. The lining shows apocrine differentiations. They're called apical snouts of decapitation secretion. The apical cytoplasm makes up the secretory product. These tend to be more multilocular, and sometimes they verge on the cystadenomatous. Congenital hemangiomas, called strawberry hemangiomas, occur in children. It's interesting that they share antigens with placental microvessels, and there's some question whether they might represent sort of like metastatic placenta. They tend to undergo involution. An immunomarker is a GLUT1. That's rather specific for this type of hemangioma. Histopathologically, we see a bunch of capillary caliber vessels. In the early stages of a lesion, the lumina may not be that apparent. When you're dealing with skin lesions in histologic sections, 2 questions are apparent initially. Question, what color is the lesion? And is it above or below the plane of the epidermis? Basal cell lesions tend to be blue or basophilic. Squamous cell lesions are composed of cells with abundant cytoplasm, and they tend to appear pink or eosinophilic. Benign lesions are situated anterior to the plane of the epidermis and because they don't have the ability to invade. In contrast, malignancies are located deep to the plane of the epidermis, reflecting their ability to invade. The benign lesion above is a seborrheic keratosis. The ulcerated basophilic lesion below is a malignant basal cell carcinoma. A variety of skin tags and benign squamous papillomas occur on the lid. The one in the top left is a rather spectacular example. The one at the bottom left is more of a skin tag, or so-called acrocordon. Histopathologically, we see benign epidermis with hyperkeratosis enveloping a central core of fibrous and fibrovascular tissue. Seborrheic keratosis, a pretty common lesion in elderly patients. In African American patients, you can have multiple pigmented seborrheic keratosis, is called dermatosis papulosa nigra. Morgan Freeman is a commonly viewed example of this. Seborrheic keratoses, again, are located anterior to the plane of the surrounding skin. They have hyperkeratosis on the surface, which gives rise to a greasy appearance, and they have characteristic pseudo-horn cysts. They're called pseudo-horn cysts because they're actually invaginations filled with keratin. If you do enough sections, the cysts will communicate out with the surface. This case also has basket weave hyperkeratosis and some slender bands of benign cells at the base, which are consistent with the adenoid variant. Keratoacanthoma is a somewhat controversial lesion. When I was a resident, we were told that these were a variant of pseudoepitheliomatous hyperplasia. They have a crater-like configuration filled with keratin and overhanging buttress of epidermis and a smooth pushing margin at the base. Some authorities now consider keratoacanthoma to be a variant of squamous cell carcinoma with a propensity for spontaneous involution. Some people refuse to make the diagnosis or will diagnose them as squamous cell carcinoma's keratoacanthoma variant. There are other umbilicated or cup-shaped lesions of the eyelid besides keratoacanthoma. Molluscum contagiosum frequently has an umbilicated appearance, and of course basal cell carcinoma is often has a crater. Here's an example of a molluscum contagiosum of the lower eyelid. Molluscum contagiosum is caused by infection with pox virus. The pox virus can get down into the conjunctiva and stimulate chronic follicular conjunctivitis. Histopathologically, here's a classic crater-shaped lesion. The infection causes lobular acanthosis of the epidermis. And we tend to see these molluscum bodies or Henderson corpuscles filled with the pox virus that tend to become basophilic as they mature. So these are called Henderson-Patterson corpuscles. If you see molluscum contagiosum in an adult or multiple molluscum contagiosum, you have to think of the possibility of immune suppression. This is a case of massive involvement of the facial skin in a patient with HIV/AIDS in the early pre-heart era of the AIDS epidemic, courtesy of Dr. Henry Perry. Here's another papillomatous lesion, the verruca vulgaris, another viral lesion. Spire-like fronds are a classic feature that suggests a viral origin. The viral inclusions and keratohyalin granules that are characteristic features may be transitory, so this spire-like configuration is suggestive of the diagnosis. Here's a rare specimen. This is a herpes simplex vesicle, one of the residents removed a few years ago. Under higher magnification, we see giant cells with the viral inclusions. There's another herpes zoster, another important viral disease that can affect the eye, cause uveitis and major problems. Most common eyelid malignant tumor in Caucasians by far is basal cell carcinoma. It's actually fairly rare in African Americans and rare in some other parts of the world. This is thought to arise from the pluripotential germ cells of the epidermal basal cell layer. It's most common in the lower eyelid. There are different growth patterns, the nodular, ulcerative, can be pigmented. There's even basal cell carcinomas with sebaceous differentiation. Tends to be blue or basophilic and below. We'll talk about the peripheral palisading and the morpheoform variant. This is a classic textbook, basal cell carcinoma. In fact, this is present in several textbooks. Why is it classic? It's involving the lower eyelid. It has ulceration. It has elevated pearly margins with telangiectatic vessels. Again, it's most common in the lower lid, followed by medial canthus, upper lid, and outer canthus. Here's another classic example. Lower lid involvement, blue and below. This is a superficial basal cell carcinoma associated with the epidermis. Now, there's other lesions that are basophilic and invasive besides basal cell carcinoma. One of the features we look at histopathologically to confirm the diagnosis is the presence of peripheral palisading and retraction artifact seen here. Peripheral palisading refers to the arrangement of the cells in the periphery of the specimen, which is perpendicular to the marginal lobule. These are sort of reminiscent of the logs in a old colonial fort or palisade. So this is peripheral palisading. Tumor also retracts from the surrounding stroma, and this is called retraction artifact. So another example of peripheral palisading and retraction artifact. Now, basal cell carcinoma typically does not metastasize. It can kill, however, particularly in these neglected cases where the tumor can actually invade the central nervous system and give rise to secondary CNS infection. A lot of these patients have the morpheoform variant, poorly differentiated basal cell carcinoma composed of infiltrating tendrils. The margin of these tumors may be relatively indistinct, and Mohs surgery probably the best way to deal with them. It's now apparent that dysregulated or aberrant hedgehog pathway signaling is implicated in the pathogenesis of basal cell carcinoma. The inhibitor of the smoothen gene, vismodegib, can be used for advanced or unresectable or metastatic disease. The drug tends to be very expensive, however, and the lesion tends to recur when the medication is stopped. Here's another blue and below lesion. This is a malignancy, Merkel cell carcinoma, a neuroendocrine carcinoma. That does occur occasionally on the eyelid. Merkel cell carcinoma is a cutaneous neuroendocrine tumor that's rare and tends to be aggressive. They are frequently this reddish appearance to them. A human tumor virus, Merkel cell polyoma virus, is integrated into the tumor cell DNA in about 80% of patients. This is a fairly common virus found in the normal flora of the conjunctiva. Sebaceous cell carcinoma, BAMP, that is not the name. It's sebaceous gland carcinoma or sebaceous carcinoma. Sebaceous carcinoma typically is found in elderly patients, has a propensity for Asians and females. I've heard that this is the most common eyelid tumor in India. 2/3 of cases involve the upper eyelid. It can arise from the meibomian glands or the Zeiss glands, the sebaceous glands of the lid lash follicles. It can also occur rarely from the sebaceous glands in the caruncle. Misdiagnosis of sebaceous gland carcinoma is common. They can mimic chalazions or chronic blepharoconjunctivitis clinically. In older series, there was a mortality, about 15%. I have seen a case of metastatic sebaceous carcinoma to the lung. Early diagnosis and treatment is essential. We'll go through the histopathology. Here's a sebaceous carcinoma, again, involving the upper eyelid. Does have sort of a yellowish appearance. This tends to be very protean in its appearance. Histopathologically, the tumor cells of sebaceous carcinoma classically have foamy, vacuolated cytoplasm. Of course, there is variations in the degree of sebaceous differentiation. Note that there's no peripheral palisading here. Larger tumor lobules undergo central necrosis, and this is called the comediocarcinoma pattern. Special stains for fat, like the oil red O, confirm that the vacuoles are composed of fat. Of course, this has to be done on frozen sections because paraffin-embedded tissue doesn't contain fat anymore. It gets dissolved out during processing. So these have to be done on fresh frozen tissue. Again, this stain really isn't done by ophthalmic pathologists that often. The diagnosis is fairly straightforward if you're familiar with the disease. Again, if you're somewhere where the pathologist may want to do this stain, you have to warn him to put some tissue behind. Put some tissue aside for potential staining. Fresh tissue is unnecessary, but it works better. Now, there is an immunohistochemical stain called adipofillin that you can do on paraffin-embedded tissue, and this can be a help. Another classic feature of sebaceous carcinoma is the invasion of the epidermis by tumor, which is called pagetoid invasion. Here we see the tumor cells in the epidermis. And another important feature is the propensity of the tumor to invade and replace the conjunctival epithelium. This can give rise to a masquerade syndrome of chronic unilateral blepharoconjunctivitis, unresponsive to therapy. Cases have also been misdiagnosed as mucous membrane pemphigoid. As noted, this is a lesion that can be misdiagnosed both by ophthalmologists and by pathologists. Recurrent or atypical chalazions should be submitted for pathologic evaluation to exclude sebaceous carcinoma or other rarer malignancies of the lid. Some rare sweat gland carcinomas can be confused with chalazion. And remember to biopsy unilateral or chronic conjunctivitis, which is unresponsive to therapy. This is an unusual case. This is a sort of pedunculated lesion, a very well-differentiated sebaceous lesion. Well-differentiated sebaceous lesions, like sebaceous adenomas, can be associated with the Muir-Torre variant of Lynch syndrome caused by germline mutations in DNA mismatch repairs. Again, this typically occurs in low-grade adenomas, and it's the association of sebaceous tumors with internal malignancies, particularly colon carcinoma. Immunohistochemistry for mismatch repair genes. We typically do this when we have a fairly low-grade sebaceous lesion. At the top, the normal cells show nuclear staining. E and is normal. F shows no staining of the nuclei of the tumor with control of normal sebaceous glands. Just because the immunohistochemistry is abnormal does not mean that the patient has a germline mutation, however, because you can have somatic mutations in some cases. Squamous cell carcinomas tend to occur in elderly patients who are fair-skinned, lower lid margins, most common site. Here's a rather spectacular example from the old Philadelphia Veterans Hospital. Again, sebaceous carcinomas are pink and below. Here's another example at the eyelid margin, eosinophilic and invasive. Here's an example of a squamous cell carcinoma arising from actinic keratosis, or perhaps squamous cell carcinoma in situ. The basement membrane is intact. On this side, there is an invasive vertical growth phase arising from the carcinoma in situ. This diagram shows the distribution of metastases from the preauricular, and this diagram shows the lymphatic drainage from the eyelid, the upper lid and lateral third of the lower lid drain to preauricular and parotid nodes, the medial 2/3 of the lower lid to the submandibular globes. Melanocytic lesions, fortunately, melanomas, malignant melanomas of the eyelid skin are quite uncommon. We do see a fair number of nevi. This is a dermal nevus from an elderly patient. Amelanotic nevi can occasionally be confused with papillomas. Here's the histopathology of a dermal nevus. There's no junctional component here. There's the Gren zone that separates the epidermis from the nests of nevus cells in the dermis. This is an example of a malignant process, a so-called Hutchinson's melanotic freckle, or lentigo maligna. This can give rise to a melanoma, lentigo maligna melanoma. And we see the clumps or aggregates of atypical malignant melanocytes at the base of the epidermis. Nevus of Oda is a blue nevus. It does not give rise to skin melanomas. And the major problem with nevus of Oda is its propensity for patients to develop uveal melanomas. This is a blue nevus. We see dendritiform melanocytes in the dermal tissues, a variant of blue nevus. This is an example of a cellular blue nevus. I've seen several cases of this during my career. All of the patients have died from CNS melanomas. Xanthelasmas may be a marker for abnormal lipid metabolism. Why they occur where they do, I have no idea why, but this is the typical location. The epidermis is normal. The process involves the dermis. We have aggregates of xanthoma cells or foamy histiocytes down in the dermis. A few other eyelid lesions are shown in this lipoid proteinosis. Urbach-Weaver syndrome is a very interesting congenital lesion that has multiple waxy nodules along the eyelid. Sweat gland tumors, syringomas, probably the most common that we see. This is a benign tumor that occurs in clumps. Histopathologically, we see these round or comma-shaped formations composed of benign eccrine sweat ductal cells. Here's another example of a syringoma. Another rare sweat gland tumor is the syringocystadenoma papilliferum. This has a squamous component on the surface, and then the cystadenoma component deeper that typically has lots of plasma cells invading this stroma. Tumors of hair follicle origin, the one you should know about is pilomatrixoma, or the calcifying epithelium of Malherbe. Trichofolliculomas and tricholamomas are pretty uncommon. There's a pilomatrixoma. They frequently are seen near the brow. They may have a reddish appearance. There's two spellings of this, pilomatrixoma or pilomatricoma. Here's an adult with a characteristic reddish pilomatrixoma. Histopathologically, they are composed of basophilic hair matrix cells, which tend to undergo necrosis, forming anucleate shadow cells. The necrotic shadow cells then may undergo calcification, and this is, you may or may not see a calcification in the It's responsible for the old term calcifying epithelioma of Malherbe. So we see these every once in a while. There supposedly is a malignant variant. I've never seen one, however.
The orbit. The contents of the orbit include the globe, the optic nerve, a tract of the central nervous system, fat, muscle, tendon, fascia, the lacrimal gland, vessels, nerves, a sympathetic ganglion, and a cartilaginous trochlea. Rarely, neoplasms can arise from almost all these items. Most orbital lesions are space-occupying, and they cause ocular proptosis and displacement. The term exophthalmos generally denotes endocrine dysfunction and is applied to thyroid ophthalmopathy. The direction of globe displacement indicates the location of the orbital lesion. For example, lacrimal gland lesions are present in the superior temporal orbit and they displace the eye down and inwardly. Ethmoid lesions like mucoceles and tumors displace the eye laterally. Maxillary sinus lesions displace the globe superiorly. Frontal sinus or superior orbital lesions displace the eye inferiorly. And optic nerve, retrobulbar, and interconal lesions produce axial proptosis. Enophthalmos classically is caused by orbital blowout fractures. It may also be caused by serous cancers like metastatic serous breast carcinoma or malignant syringoma or microcystic carcinoma. In general, inflammatory diseases and pseudotumors of the orbit are much more common than true neoplasms. Here's a golden oldie, a patient with the Graves' orthopathy, goiter, and exophthalmos. Graves' orbitopathy, thyroid eye disease, is the most common cause of exophthalmos. The proptosis is caused by enlarged extraocular muscles. One finds patchy chronic inflammation in the muscle that spares the tendon and orbital fat. It's an autoimmune disorder. Autoantibodies are known to attack a signaling complex composed of IGF-IR and thyrotropin receptors, causing severe inflammation and expansion of the orbital muscles and fat cells. IGF-IR is insulin-like growth factor 1 receptors. These are overexpressed on the orbital fibroblast in Graves' disease. The autoantibodies attack the signaling complex composed of IGF-R and thyrotropin receptor TSHR, causing severe inflammation and expansion of orbital muscle and fat cells. A newly improved medication, trepotumumab, seems to be effective for thyroid ophthalmopathy and blocks the IGF-IR. Here's a diagram showing that immune response. Exophthalmos is due to marked enlargement of the extraocular muscles. This is a specimen that we dissected many years ago. It was a patient who was admitted for radiation therapy of thyroid optic neuropathy and died in the hospital from a heart attack after receiving one treatment. The extraocular muscles are massively enlarged. The superior muscle measured 14 by 8 millimeters.
The gross photographs above compare the extraocular muscles of a normal eye with the massively enlarged muscles of our patient with thyroid optic neuropathy. Note that the photo of the normal eye is somewhat enlarged compared to the eye with thyroid disease. The swollen bellies of the extraocular muscles compress the optic nerve in the eye with Graves' disease. Histopathology of the muscle shows endomysial fibrosis with glycosaminoglycan deposition and foci of lymphocytic infiltration.
Idiopathic orbital inflammation or idiopathic inflammatory pseudotumor tends to be a symptomatic process. There's frequently an explosive onset, there's pain, there's muscle palsy, there's proptosis, and there may be visual loss. Pseudotumor can be acute or chronic, be unilateral or bilateral. It's generally exquisitely sensitive to steroids. Steroids are actually used as a therapeutic trial in some instances. Histopathologically, one finds a polymorphous infiltrate of inflammatory cells. We have lymphocytes, plasma cells, histiocytes. Cases with fibrosis may be appear relatively eosinophilic, and fibrosis can be massive in sclerosing cases. And the presence of fibrosis suggests the possibility of IgG4 related disease. And here's histopathology showing atrophy of the lacrimal gland, foci of polymorphous inflammation, and eosinophilic fibrosis. Some cases of sclerosing pseudotumor may have IgG4 related disease. This does not affect the therapy, but these patients are at risk for other systemic sclerosing conditions. Here is a case of IgG4 related disease we saw in our laboratory. You tend to see follicular lymphoid hyperplasia, storiform fibrosis, see plasma cells and eosinophils. The immunohistochemical stain shows a significant number of IgG4 positive plasma cells. Diagnostic criteria are somewhat variable. 100 IgG4 positive plasma cells per high power field is a criterion in one study. Idiopathic orbital inflammation is a diagnosis of exclusion. Lymphoma or another specific inflammatory disorder like sarcoidosis or granulomatosis with polyangiitis or aspergillosis need to be excluded. Here's an example of the sarcoid dacryoadenitis with the S-shaped lid fissures and the discrete non-craziated granulomas in the lacrimal gland. This patient has granulomatosis with polyangiitis, what was once termed Wegener granulomatosis. This patient's biopsy does have granulomatous vasculitis and necrosis. However, orbital biopsies are often nonspecific, and the C-ANCA test is often helpful diagnostically, but is not always positive. This is an example of mucormycosis. We see very large fungal hyphae that are evident in the H&E stain section. These are present within necrotic orbital fat in this field. In the inset, we see the fungal hyphae invading blood vessels, causing thrombosis. Lymphoid tumors of the orbit are some of the most common orbital lesions. They are diseases of the elderly. Average age is about 60. Again, they frequently cause insidious, painless proptosis. They may have a salmon patch in the conjunctiva. 90% involve the superior orbit behind the orbital septum. There's frequently lacrimal gland involvement. The tissue is soft and tends to be molded by the tissue planes. The great majority of these are low-grade lymphomas. More than 50% or more are extranodal marginal zone lymphomas of mucosa-associated lymphoid tissue. The association of orbital lymphoid tumors with systemic disease is higher than that seen in the conjunctiva. In one series, 35% of the patients would develop or had concurrent systemic lymphoma. These patients need to be worked up systemically. This montage shows the fish flesh-like appearance of the gross tumor specimen. Number B shows follicular lymphoid hyperplasia with tingible body macrophages in the follicle. We see a low-grade lymphoid infiltrate on the bottom left, consistent with a malt lymphoma. Occasionally, we will see high-grade large cell lymphomas as well. So, fish flesh appearance to the tumor. They are monomorphic monoclonal maltomas. We do see a different spectrum of orbital tumors in adults and children. The vascular lesion in adults are cavernous hemangiomas. We see capillary hemangiomas and lymphangiomas in children. Neural tumors in adults include meningiomas and schwannomas. In children, we see plexiform neurofibromas and optic nerve gliomas. Solitary fibrous tumor, most common mesenchymal tumor in adults. Fibrocystomas probably actually are solitary fibrous tumors in most instances. Embryonal rhabdomyosarcoma is the typical mesenchymal tumor in children, albeit quite rare. You can have epithelial tumors of the lacrimal gland, dermoid cysts, and teratomas in children. Lymphomas, of course, are very, very common orbital tumors. Orbital lymphomas are very uncommon in children. If you see what looks like a lymphoma, think of the possibility of a myeloid sarcoma or a histiocytic disorder. Lung and breast metastases occur in adults, metastatic neuroblastoma and Wilms tumor in children. Well-circumscribed orbital tumors, circumscription can suggest diagnoses in imaging studies. By far, the most common well-circumscribed tumor is the cavernous malformation or hemangioma. Schwannomas are also well circumscribed, and so are solitary fibrous tumors. Again, lesions that previously were called fibrocystomas and hemangiopericytomas actually are now classified typically as solitary fibrous tumors. Epithelial tumors of the lacrimal gland also tend to be well circumscribed. This is a woman who had a chronic cavernous hemangioma. She has proptosis. The sclera is showing at the inferior limbus, and she also has this doughy chronic orbital edema involving her lower lid. Cavernous hemangiomas or malformations are composed of large cavernous blood-filled spaces. They tend to be encapsulated. After fixation, they have a sort of a bluish, pebbly surface to them. The endothelial-lined cavernous blood-filled spaces are separated by stout septa, which frequently contain bundles of smooth muscle. Here's a well-circumscribed solitary fibrous tumor. They can have sort of a storiform appearance to them. They also may have a hemangiopericytomatous pattern of blood vessels with staghorn-like vessels. They are immunoreactive for CD34, but the stain of choice, the pathognomonic stain, is STAT6, a nuclear stain. Solitary fibrous tumors may have a patternless pattern with wire-like collagen bundles. Again, STAT6 positive, CD34 positive, BCL2 positive, and CD99 positive. As I stated before, many cases diagnosed previously as fibrocystocytoma or hemangiopericytoma would now be classified as solitary fibrous tumors. Here's a case that we had in the first edition of my textbook as a hemangiopericytoma. This is what it was diagnosed as many years ago. It had the classic staghorn vessels, sinusoids. We actually retrieved the paraffin block from this case from our archives and performed the STAT6 stain, and of course it was positive, consistent with a solitary fibrous tumor. Schwannomas, peripheral nerve sheath tumors, arise from branches of the fifth nerve. They are well circumscribed and encapsulated. Here's another example of a well circumscribed schwannoma. Typically have nuclear palisading, the Antony A pattern, Verricae body formation. There's the Antony A pattern, the nuclear palisading. They can also have these loose vacuolated areas, and that's called the Antony B pattern, so schwannomas. This man has down and inward proptosis. He has a lacrimal gland tumor. Lacrimal gland tumors, Algernon Rees, the father of American ocular oncology, had a 50-50 rule, which is 50% true. In his series, he had said that about 50% of the lacrimal gland tumors were inflammatory. Actually, in average clinical practice, a much higher percentage of lacrimal gland lesions are inflammatory or lymphoid. Epithelial tumors of the lacrimal gland are fairly rare. The second part of it, Rees's rule, is true. 50% of the epithelial tumors are benign, generally pleomorphic adenomas or benign mixed tumors. 50% of the epithelial tumors are malignant. There's a large spectrum of malignant lacrimal gland tumors. A lot of them are quite rare. The most common malignancy is the adenoid cystic carcinoma. So again, lacrimal gland lesions, 50% benign, generally pleomorphic adenoma, and 50% malignant, typically adenoid cystic carcinomas. This is a gross specimen of a pleomorphic adenoma. Again, if you suspect a pleomorphic adenoma, you do not want to biopsy the lesion. You have to excise them in toto. If you don't, you have tend to seed the orbit with tumor cells, leading to recurrence as multiple little tiny unresectable tumors that may undergo malignant transformation. Clinical signs of malignancy include long duration of symptoms, absence of pain, the presence of a well-corticated fossa in the orbital bone. In contrast, signs of malignancy include short duration, presence of pain, bone erosion, and calcification. Here's a well-circumscribed pleomorphic adenoma with the corticated fossa in the bone. Pleomorphic adenomas are also called benign mixed tumors, reflecting the fact that they're composed of a mixture of epithelial ducts and mesenchymal stroma that can include fibrous, myxoid, and chondroid tissue. Now here's the classic cribriform or Swiss cheese pattern of adenoid cystic carcinoma. This is just one of the growth patterns, but it's a very characteristic pattern that they frequently show on at examinations. This is a poorly differentiated form of adenoid cystic carcinoma, the basaloid variant. Patients whose tumors have a basaloid component have a poorer prognosis. Adenoid cystic carcinoma typically is painful due to perineural invasion, shown here and in this photomicrograph. This is a case of congenital teratoma, rather disturbing picture. This was a benign tumor. Patient did lose the eye, however. As we stated before, a different spectrum of orbital tumors occurs in adults and children. The most common orbital lesion in childhood is the dermoid cyst or cystic dermoid. This is filled with foul-smelling keratin debris, which frequently contains hair shafts. It's sort of like somebody mixed hair with your cream cheese. Histopathologically, the dermoid cysts are lined by stratified squamous epithelium with epidermal appendages. Again, we see hair shafts mixed with the keratin within the lumen. Epidermal inclusion cysts, which occur on the eyelid, result from the cystic dilatation of a single epidermal appendage, a hair follicle. They are follicular cysts. In contrast, dermoid cysts result from the entrapment of skin with its dermal appendages in a bony suture in the developing skull. Capillary-hemangiomas tend to be multilobular. Lymphangiomas are part of a disease spectrum that includes orbital varices. You may have chocolate cyst formation by hemorrhage into the vascular lumina. There is also frequently foci of lymphocytic infiltration and follicles associated with the lymphatic channels. These may be responsible for enlargement during upper respiratory infections. Here's an 8-year-old child with a superior orbital mass. She has an orbital rhabdomyosarcoma. This is an old picture. She was treated and has done very well. The mean age for orbital rhabdo is about 7 or 8. They typically involve the superior orbit, and there's usually fulminant proptosis. Rapid growth of the lesion can mimic inflammation. Most cases of orbital rhabdos in children are embryonal rhabdomyosarcomas that lack cross striations. The diagnosis is confirmed with immunohistochemistry. There are also rare botryoid, alveolar, and pleomorphic variants. An expedient biopsy should be performed. Most cases are treated with chemo and radiotherapy. Survival is 80% if there is no involvement of the paranasal sinuses. always consider rhabdo in any child with orbital disease. Again, rapid growth can mimic inflammation. Here's histopathology of an embryonal rhabdomyosarcoma. It's a spindle cell tumor sarcoma. You may have strap cells with straps of eosinophilic cytoplasm, reflecting muscle differentiation. Here's an additional H&E stain section. Here's a case with more muscle differentiation. Actually see cross striations in this case in a rhabdomyoblast, but these are fairly uncommon. Alveolar rhabdomyosarcomas have a poorer prognosis than embryonal rhabdomyosarcomas. There is a characteristic, or several characteristic gene fusions involving the PAX3 or PAX7 gene and the FOX FOX01 gene. Tumors that have the PAX3 fusion have a much poorer prognosis than patients with the PAX7 fusion protein. You confirm the diagnosis of rhabdo using immunohistochemistry for markers of striated muscle differentiation like desmin or muscle-specific actin. We can also look for transcription factors like MyoD or myogenin. Myogenin is a nuclear stain. Desmin is a cytoplasmic stain. The transcription factors like myogenin and MyoD are more specific and, of course, are nuclear stains, not cytoplasmic stains. They're more specific. Here's our example of a alveolar rhabdomyosarcoma. These epithelioid rhabdomyoblasts filling these spaces denominated by septae, which are sort of reminiscent of the alveoli in the lung. And we discussed the translocations already. This is showing a positive muscle-specific actin stain. This is a botryoid rhabdomyosarcoma, a rhabdomyosarcoma associated with mucous membrane. It's termed botryoid because it has this fanciful resemblance to a bunch of grapes. This is an old case from Lubbock, Texas. I remember talking to the clinicians involved in this case. They said they could see the tumor grow from morning to evening rounds. Here's histopathology of another botryoid rhabdo associated with the conjunctival epithelium. Here's a histiocytic lesion of the orbit, typically involves the orbital bones. Langerhans cell histiocytosis variant of eosinophilic granuloma, mixture of eosinophils and Langerhans cells. CD1A is one of the immunohistochemical stains that we use to confirm the diagnosis. They are also positive for S100 protein. Here's an example of Burkitt's lymphoma. As I said before, lymphomas are pretty uncommon in children, the exception being Burkitt's in certain portions of the world. This is a high-grade B-cell lymphoma that can have these tingible body macrophages. These are responsible for the so-called scarry sky appearance. Another rare histiocytic disorder is Rosai-Dorfman disease. This is also called sinus histiocytosis with massive lymphadenopathy. You have these very large histiocytic cells with these large nuclei with nucleoli, but the classic feature is the presence of phagocytosis of lymphocytes by the histiocytes, and this is called emperipolesis. So Rosai-Dorfman. Secondary orbital tumors include metastases and direct infiltration by contiguous structures. Eyelid tumors like basal cells, squamous cells, sebaceous gland carcinoma, or melanomas can invade the orbit. We see more conjunctival tumors invading the orbit at wills, invasive squamous cells, melanomas, mucoepidermoid and spindle carcinomas. Intraocular tumors can also extend extraocularly. You can have orbital invasion by melanomas and retinoblastomas. Mucoceles and carcinomas can impinge on the orbit, and meningiomas and esthesioneuroblastoma of the CNS can also invade secondarily. This photomicrograph shows the classic linear pattern of metastatic breast carcinoma, usually lobular breast carcinoma. This is termed the Indian file pattern. This refers to Native Americans in a war party walking one behind the other on a narrow trail in the forest. You can also see mucin-containing signet ring cells.